Hello there, my name is Emily Lau, and I'm one of the cardiology fellows, and I'm here to talk to you about intra-aortic balloon pump, or Iabp, otherwise known as the balloon pump. This is a type of mechanical support device that you'll see most commonly used in the coronary care unit or in the cardiac surgical ICU. The whole principle behind a balloon pump is that it is a mechanical device that is meant to help support our cardiac function. So it is essentially an extremely long balloon that is placed in the cath lab through a femoral access point, and then it resides in between the great vessels and the renal arteries. There is a point, there's sort of a dark pigmented point that can be seen with X-ray guidance that should always be about 1 to 4 centimeters below the aortic arch. And so that's something to keep in mind when you monitor for the position on the chest X-ray every day. So what's the whole concept behind the balloon pump? Well, the balloon pump does one of two things. It inflates and it deflates, just like a regular balloon. And it inflates during diastole and it deflates during systole. And the whole point of the balloon pump really is to help cardiac function by improving myocardial oxygen supply and reducing myocardial oxygen demand. So how does it do that? So when the balloon inflates in diastole, it increases the coronary perfusion pressure. So that is essentially improving our oxygen supply because we're getting more blood flow to our coronary arteries. Now, when it deflates in systole, it actually decreases the systemic vascular resistance, which then decreases the oxygen demand. So that's really an important principle and really a simple one to understand. The balloon pump only does one of two things. So if you can remember that concept, you can sort of talk yourself through what it is that the balloon pump is doing at each point. Let's use this framework to think about the indications for a balloon pump. So if we focus specifically on the inflation during diastole, where we're increasing the coronary perfusion pressure or increasing oxygen supply, what sort of things might a balloon pump be useful for? So I think of this as trying to improve coronary perfusion in cases of ischemia. So for instance, if somebody is having refractory myocardial ischemia, and that might be somebody who's having refractory chest pain and needs to be bridged to cath, or somebody who's actually having refractory ischemic VT. The balloon pump is perfect, a perfect device for this population because you are increasing your diastolic coronary perfusion pressure and thereby trying to reduce the amount of ischemia to eventually get your patients to where they need to be. More commonly nowadays, we will see that balloon pumps are actually used as a way to facilitate revascularization. So we see in cases that are more complex that balloon pumps are used as an assist device. So balloon pump assisted PCI or balloon pump assisted CABG. So now if we move on to the other side of the equation, where the balloon pump also, when it deflates in systole, where it thereby decreases the systemic vascular resistance and ultimately decreasing oxygen demand, what sort of conditions might be important, might a balloon pump be important in managing these conditions? So one example might be valvular heart disease. So in severe mitral regurgitation, one very important thing that we can do is to decrease the afterload. And that's because the higher the afterload you have, the increased amount of regurgitation. So a balloon pump could be very helpful in that scenario because it actually reduces the afterload that the MR is seeing. Now, in mechanical complications of MI, you can also see MR due to an acute papillary muscle rupture. So that is another indication for a balloon pump. papillary muscle rupture. But also something we don't see very commonly today are VSDs. And it's the same concept here. You decrease your SVR, decrease the amount of shunting across the VSD. Finally, probably the most common understood indication for balloon pump are in cases of cardiogenic shock, where you're using the mechanical device to support really to augment cardiac output. And so that might be related to somebody who's just had an acute MI, or more commonly nowadays, somebody who has a longstanding cardiomyopathy, who needs additional cardiac support. So in this scenario, you can imagine that the balloon pump, both its ability to increase oxygen supply through increasing perfusion pressure and its ability to decrease oxygen demand by decreasing the SVR would be very important in supporting these patients. One thing to know is that we now have a number of other assist device, mechanical devices such as Impella or ECMO, which actually are able to provide a significant amount more cardiac output than balloon pump are able to, because as we recall, balloon pumps really provide about 0.5 to 1 liter of cardiac output, in addition to what our native system is able to do. So that's not a lot of cardiac output. And so if you're somebody who has a cardiac index that's in the low ones, this may not be adequate to be able to support whole body perfusion. But it really was the only device that we had available a while back. So this is still an important indication, but we're seeing less and less of balloon pumps used in this scenario. Now that we've gone through the indications, how about the contraindications? In this scenario, I think I try to think of contraindications as, where is the device sitting and what makes it feasible to be able to actually place this device in a patient. So, for instance, we know that the access point is in the femoral artery. So if somebody has severe peripheral arterial disease, we are not going to be able to deliver the apparatus of the balloon pump toward the heart. So that would be a contraindication. And of course, this is an intra-aortic balloon pump. So the balloon actually sits within the aorta. So if somebody has significant aortic pathology, whether that be an aortic dissection or an aneurysm, that would be an absolute contraindication. And then finally, the balloon pump is near the aortic valve. So if somebody has severe aortic insufficiency, that would not be the right patient to put a balloon pump in. And then finally, a contraindication that I don't always think about. All mechanical device supports really are to be used as a bridge to some sort of therapy. So if you really are at a place where the patient cannot be bridged, there's nothing left besides the balloon pump, there's no hope for some sort of recovery, you're really bridging them to nowhere, in which case it really isn't appropriate to be going down the pathway of putting in a balloon pump. So let's take a moment to review the waveforms. What will you actually see on the arterial line when somebody has a balloon pump in? So this is the unassisted waveform. So this basically looks like an A-line tracing. And what you see, as you all recall, is this figure that has a little bump in it, which we call the dicrotic notch. And you can see here that at the bottom, at the trough, that's where the aortic valve opens. Then the arterial pressure begins to rise. You hit the peak blood pressure. Then it starts to fall again, and that's where the aortic valve closes, creating a dicrotic notch. And then we see the arterial pressure declining down to the trough again. Okay, and now let's review an assisted waveform. So this is a scenario where the balloon pump is being inflated every second beat. So we call that 2 to 1. So this is the native arterial line waveform here, and this is the unassisted aortic end diastolic pressure, and this is the unassisted systolic blood pressure. Now at this point here, where you would normally see a dicrotic notch, the balloon pump actually inflates. And as a result, you end up getting this augmented blood pressure here. And then here, the balloon pump deflates. And as a result, you see that the balloon pump assisted end diastolic pressure is actually lower than the unassisted. You can see that in comparison. So this augmented blood pressure is increasing coronary perfusion because this is happening during diastole. And then this decrease in the end diastolic pressure is decreasing the systolic vascular resistance. And then if you look at the next beat here, this is now an unassisted beat. There's no balloon pump being activated, but you can see that the balloon pump has increased the systolic blood pressure as compared to the prior one here. So if we look at the difference between the unassisted end diastolic pressure and the augmented blood pressure, which again is the diastolic blood pressure, this represents increased oxygen supply due to increased coronary perfusion. And then if we look at the difference between the blood pressure, the balloon pump assisted blood pressure and the previous blood pressure, end diastolic blood pressure here. So now, if we look at the difference between this diastolic blood pressure here and then the balloon pump assisted diastolic pressure, that difference is the decrease in afterload that happens during balloon pump deflation, which thereby decreases oxygen demand. Now, most of the time the balloon pump is on what we call 1-to-1, which means the balloon pump is inflating every beat, inflating and deflating every beat. And so the waveform looks more like this. You can't tell the difference between what's assisted and not assisted because they're all assisted. And that's in comparison to what we were looking at earlier, which was something that looks more like this, which is 2-to-1, where the balloon pump is inflating and deflating every second beat. Typically, when a patient needs maximal balloon pump support, we have the patients on what we call 1-to-1. Certainly, when you're rounding on these patients, it's very difficult to auscultate them with the balloon pump going at 1-to-1. So oftentimes, we might even stop the balloon pump just so we can listen to the heart and lungs. But this is a really important time that you can actually watch what happens to the hemodynamics of a patient when you transiently stop the balloon pump. So, for instance, you can look at their A-line tracing to see if their blood pressure decreases, if their pulse pressure widens, or if it decreases. So, for instance, if the pulse pressure becomes more narrow and the blood pressure drops, it might suggest that the patient's actually quite dependent on the balloon pump. And if it doesn't make much of a difference, then potentially they might be able to be weaned off the balloon pump, which we'll talk about in a moment. And then, if somebody has a PA line, it's really important to look at somebody's filling pressures to see if, for instance, their LV end diastolic pressure, which is a measure of wedge pressure, or their LV filling pressures go up when you when you actually stop the balloon pump. So really use every opportunity you have to be able to assess what your mechanical support device is doing to your hemodynamics. So the last thing I want to talk about is a balloon pump wean. So you maybe had a patient who had an acute MI, you were supporting them, you're supporting their hemodynamics, and they've actually had some recovery. You've noticed that their hemodynamics are getting better, and now you are interested in seeing if they'd be able to fly without the support of a balloon pump. So that's when we approach something called a wean. So remember, I mentioned that at 1-to-1, the balloon pump is being inflated every beat. At 1-to-2, and I apologize, I think I earlier said 2-to-1. I meant to say 1-to-2. So every second beat, the balloon pump inflates. And then 1-to-3, it's every third beat. You get the idea. So in a wean, you can start somebody off at 1-to-1, which is where they're at, and then move them to 1-to-2. And you can keep them there for a few hours or even longer. A fast wean might be a couple hours. A slow wean might be, 6 to 8 hours. And then if they do well, looking at all the hemodynamic parameters that we had talked about before, you can then move them to 1-to-3. Same idea. And then if everything looks good at 1-to-3, you might say, okay, I think this person's going to fly. So you put them back at 1-to-1, and we'll talk about why we need to put them back at 1-to-1. And then you go and you can proceed to pull the balloon pump. So the reason that we need to keep somebody at 1:1 right before we pull the balloon pump is that at 1:1, the risk of thrombosis is much lower, so we do not actually need to be heparinizing the patient during that time. And that is important when you pull it because you want to reduce the risk of bleeding. However, once you're at 1:2 or 1:3, the patients must be therapeutically anticoagulated because the risk of thrombosis is extremely high. So that's pretty much all I have about balloon pumps. A really cool tool that we get to use in the CCU. It's actually a pretty simple pump. You inflate the balloon, you deflate the balloon, and the whole concept is increasing oxygen supply through increasing coronary perfusion when the balloon inflates during diastole, and then decreasing oxygen demand by decreasing the systemic vascular resistance when the balloon deflates in systole. I hope that was a great talk, and I can't wait to talk to you soon. Bye.